You're welcome.
Can you see my slides?
Not yeah, now it's seen.
Slideshow?
Not yet. Yeah, now it's slideshow.
دكتور
Okay.
بليز بس السلايد اللي قبليها انا دخلت ما لحقتهاش، فلو ممكن
This
تعرضي
one?
تاني.
This one?
اللي قبليه دي
Type. This is an axial CT of the neck. If you can see me, it's cut like that. Okay. This is anterior. Let me put the laser pointer. This is anterior, and this is posterior. This is right, and this is left. Because you're cutting the patient's neck like that, and you're looking from the feet. Okay. So this side would be the right side of the patient, and this side would be the left side of the patient. Okay. So bone appears white. So this is the cervical vertebra. Okay, air appears black. So this is the trachea. In front of it is the isthmus. This is the right thyroid lobe, and this is the left thyroid lobe. Okay, behind the thyroid is the adenoma. This is a right parathyroid adenoma. Is it clear? Huh? Are you following me?
Yes.
Yes دكتور yes.
Okay,
Yes.
great. So
شكرا
now,
حضرتك.
okay, now we come to the enhanced chest CT. I was telling you, enhanced means what? The patient received intravenous contrast. So let me revise the anatomy with you again. This is anterior, this is posterior, this is right, this is left. This is the vertebra, bone appears white. These are the ribs, okay, they are white. These are the scapulae here, all right? And what is this white structure here? What is this? Who can tell me? Huh? Remember, the patient was given intravenous contrast. This one. What is this structure?
Aortic arch?
Yes, this is the ascending aorta, the arch of aorta, and this is the descending aorta, the starting, yeah. Type. Now, here is the area of the anterior mediastinum. It should be empty, but what is this structure? The arrow is pointing at what? This is an ectopic parathyroid adenoma in the anterior part of the superior mediastinum. You know that normally in all of us, we have 4 parathyroid glands. They are located behind the thyroid gland, 2 superior and 2 inferior. But mind you, there are ectopic sites for parathyroid glands. These become problematic when they become adenomatous, or they develop an ectopic parathyroid adenoma. This is why before sending a patient with primary hyperparathyroidism to surgery, the surgeons, they require that we do either a system scan or an enhanced CT chest to detect presence of ectopic parathyroid tissue. Okay? Now, MRI in hyperparathyroidism. It looks similar to CT, but it appears blurred, you see? This is again anterior, and this is posterior. This is right, and this is left. Air appears also black. So these are the lungs. This is the trachea. But where is the thyroid? It's gone. Why? Because we are at a lower level. We are here in the mediastinum. Okay? This is the vertebra. Okay? And this is T1 weighted image. T1 weighted. How do we know T1 from T2? By the CSF. The CSF here is black. So this is a T1 weighted image. So here you can notice the thyroid is gone. We are at a lower level. And this is a parathyroid adenoma in the area of the paraesophageal tracheoesophageal gutter. Okay? And this is the same picture of the adenoma in axial T2 weighted. How do we know it's T2? Here the CSF turned white. Okay, the same. Trachea is still black. No thyroid tissue because we are lower down in the mediastinum. And this is the parathyroid adenoma, which is iso-intense. It has the same signal intensity like this structure. And it is present in the paraesophageal tracheoesophageal tract. Okay, so this is another MRI showing an ectopic parathyroid adenoma. Is it clear?
Yes, doctor, it's clear.
Okay. Now, another form of scintigraphy, what we call technetium-99 sestamibi scan. Sestamibi is the carrier protein for radioactive technetium. So here, radioactive technetium is carried on this protein and it is administered to the patient, okay? And then they take images, delayed images. It can be colored like that, or it can be black and white, like in the coming pictures I'm going to show you. Here you see the thyroid has still, technetium can be taken up by the salivary glands, like here, the submandibular salivary glands, by the thyroid gland, and by the parathyroid gland. So this is why they take delayed films, because early all these structures light up because they have taken up the radioactive material. But if you do a delayed film, the radioactive material will be already cleared from the salivary glands and the thyroid. But if it's still present in a structure, this means it is the parathyroid adenoma. So here, this patient has a left inferior parathyroid adenoma. This one, okay? Okay, and here is the black and white version. This is an early film. So here the salivary glands are visualized and the thyroid and the adenoma. Okay, but then you see the delayed film reveals only the adenoma, the left inferior parathyroid adenoma. Okay. Now, technetium sestamibi scan is ideal for diagnosing ectopic parathyroid adenomas. Like here, you see, here there is nothing visible whatsoever in the neck, but the radioactive technetium is concentrated in the superior mediastinum. It was proven after surgical removal of this tumor that it was an ectopic parathyroid adenoma. Okay, is it clear? Any problems
Yes,
so
doctor.
far? Okay, great. So in order to diagnose ectopic parathyroid adenomas, we can do either an enhanced CT chest, but better, the best technique is to do a technetium-99 sestamibi scan. Nowadays, they also resort to 4-dimensional CT. It uses a lot of intravenous contrast because they do the venous phase, the arterial phase, and so on, and they can, through these pictures, detect whether it is a parathyroid adenoma or not. But I haven't included the pictures because it's not very commonly done. Okay? I thought it would be a bit difficult for you, Yan. Any problems so far?
No, doctors.
Okay. So now we shift to hypoparathyroidism. Quite the reverse. There are several clinical types, as you know. Acute hypoparathyroidism, which presents with overt tetany. And we have the chronic hypoparathyroidism, which is characterized by latent tetany associated with ectodermal and CNS changes. Okay? So in acute hypoparathyroidism, the patient presents with paresthesia, abnormal sensation, and numbness around the mouth and in the extremities. Muscle spasms, especially in the hands and feet, like the carpal and pedal spasm. And the most dangerous of all is spasm of the laryngeal muscles, which may lead to stridor and death. Okay? And tonic-clonic spasm may lead to convulsions. But here, mind you, in the history, you need to distinguish between tonic-clonic spasms of grand mal epilepsy and tonic-clonic epileptiform convulsions, يعني, which look like convulsions, but they are not convulsions. Why? Why is that? I will tell you a patient that I have seen a long time ago. He was a young boy, adolescent, يعني, he was 16 years old. He was obese and he was short. He had a round face and he was mentally a bit subnormal, right? And he had also some skeletal malformations. But leave them apart for now. In the history, the patient's mother came telling us her son had convulsions. So she brought him to the neurology department at Nariman Hospital, where they diagnosed him as having grand mal epilepsy, and they gave him epanutine. but the patient didn't improve. The convulsions kept going on. I don't know how he was referred to our department, I mean to the endocrine clinic. We noticed the features, the abnormal features, short stature with obesity, rounded face, mental subnormality. Immediately, we asked the patient, do a fist like that, okay? Would you please all do a fist? If you do a fist, if you can see my hand, you can see the knuckles, right? The knuckles are all visible, but not in this gentleman. In this boy, he had a pit here and a pit there. Why? Because he had shortened fourth and fifth metacarpal bones. So instead of the head of the metacarpal bone being at the knuckle where it should be, it is lower down. So at the place of the head of the metacarpal bone, there is a pit. So we diagnosed him immediately as having pseudohypoparathyroidism. All right? I will tell you about that type. When we started analyzing the history of the convulsions, the mother stated that he didn't have an aura. Usually, grand mal epilepsy patients, they feel the fit is about to come. I will experience a fit in a while. I feel the fit is coming. But in these epileptiform convulsions, there is no aura. And then during the fit of grand mal epilepsy, the patient can injure himself because he's completely unconscious. He can bite the tongue, and if he's, for example, if he's walking in the street, he may fall on the sidewalk, injuring his head, and so on. But in epileptiform convulsions, the patient is conscious, but he's not responsive. Yani, I mean, he's not able to talk, but he can tell you, I heard you whispering in my ear. I heard you shouting my name. I heard you say, bring some eau de cologne for the patient. I'll call the ambulance. So the patient is conscious. And then after the convulsions in grand mal epilepsy, the patient passes into deep sleep. But in the epileptiform fits, the patient regains consciousness immediately. In addition, I forgot to tell you, during the fit in grand mal epilepsy, the patient can also have involuntary urination. While in the fits of epileptiform convulsions, this does not occur. So just by the history, actually, if you take very meticulous history, you can distinguish between the tonic-clonic convulsions of grand mal epilepsy and the tonic-clonic spasms of epileptiform fits. Okay, is it clear? Any problem so far?
Clear, doctor.
Okay, in chronic hypoparathyroidism, there is latent tetany, which is revealed by special signs like Chvostek's and Trousseau's signs. I will show you videos thereof in a minute. And there are also ectodermal changes like dry, scaly skin, brittle and sparse hair, rigid nails with white patches, lens opacities, again, and abnormalities of the teeth. And there are also other CNS changes like mental abnormalities, epileptiform attacks, and papilledema. Okay? So what is Chvostek sign? Here you ask the patient to relax his facial muscles, and then you stand directly in front of him and ask him to open the mouth a bit, like that. And then you tap the facial nerve, either just anterior to the earlobe or below the zygomatic arch or between the zygomatic arch and the corner of the mouth. Here. Normally nothing happens, but a positive Chvostek sign would be twitching of the lip at the corner of the mouth to spasm of all the facial muscles on that side, depending on the severity of hypocalcemia. Okay? Let me show you the video. One minute, I just happened to close the right. Can you still see my slides?
Yes, doctor.
Okay. Yes, here's the Chvostek sign. Let me open the video first. Okay. Can you see the video now?
Yeah.
Okay. Type. See? Here the doctor is tapping in front of the ear tragus. Notice the twitches? Can you see the twitches? They are even more visible on the other side. See? See? Twitches at the angle of the mouth. Can you see them? Did you see
Yes,
them?
doctor.
You want to see the
Yes,
video
doctor.
again? Huh? You want to see the video again? Sorry?
Okay.
Okay. You see? See the twitches? Here. See? The more severe the hypocalcemia, the more pronounced are the twitches. Okay? Right. Let me continue. Can you see my slides?
Yes, doctor. Slide.
They are in slideshow now?
Yeah.
Okay. So this is the Trousseau sign. What is the Trousseau sign? First of all, you measure the blood pressure of the patient to know what the systolic blood pressure of the patient is. Suppose it is 120 by 80. So the next thing you do is you inflate the sphygmomanometer cuff to 10 millimeters mercury above the systolic pressure that you measured. So you inflate it to 130 and you leave it at that for 3 minutes. You ask the patient to extend the hand like that. Okay? If during those 3 minutes at any time this carpal spasm occurs, this is a positive Trousseau sign. All right? Is it clear? Let me show you the video. Can you still see my slides? Or do you see the video?
No, it's slides.
The slides, okay. Can you see the video now?
Yes, doctor.
Okay. You see? Here the patient's hand is extended. You see? And the doctor raised the pressure in the sphygmomanometer cuff to 10 millimeters mercury above the systolic. The first thing that happens is flexion of the thumb or adduction of the thumb, and then flexion of the hyperextended fingers, then adduction of the fingers, and then at the very end, flexion of the wrist and elbows. Of course, this maneuver is very painful, so you have to assure the patient, please bear with me. This is a very important sign that I need to elicit to be able to diagnose your condition. And why do we have to do it for until 3 minutes? Because if the patient has mild latent tetany or mild hypocalcemia, it will not happen immediately or after 30 seconds or after 1 minute. So it may happen, the carpal spasm may happen, let's say at 2 minutes or at 2.5 minutes. So if you don't stay until 3 minutes, you may miss Trousseau sign. Okay? So if you stayed the whole 3 minutes and no carpal spasm occurred, then Trousseau sign is negative. Okay? But if it became positive, you need to state it carpal spasm occurred at like مثلا 1 minute, at 30 seconds, and so on. Okay? Is it clear? You want to
Yes,
see the
doctor.
video again? Could you
No,
appreciate
it's
the... Okay. Okay. Sorry. Let me continue the slides. Just tell me once you see my slides again. Can you see my slides?
Yes, doctor.
In slideshow?
Yes.
Okay. This is tetany. Tetany occurs without occurs in acute hypoparathyroidism. It occurs without having to do the Trousseau sign, okay? Spontaneous. And the same picture can be seen also in the feet, pedal spasm, carpopedal spasm, okay? Now, what are the investigations of hypoparathyroidism? I told you the biochemical imaging is very important. So we measure serum ionized calcium. It's better to measure the ionized calcium because sometimes if you measure the total serum calcium and the patient happens to have hypoalbuminemia for any reason, then you need to adjust to calculate the corrected calcium. So it's better to do the serum ionized calcium, all right? You need also to measure the 24 hours urinary calcium excretion. And you need to check serum phosphate level. You will find it to be high. And you need to check the parathyroid hormone level. You will find it low. Here, unlike in hyperparathyroidism, you will find alkaline phosphatase is normal. In hyperparathyroidism, the alkaline phosphatase was high. Why do you think is alkaline phosphatase high in hyperparathyroidism but not in hypoparathyroidism? Who can tell me? Huh?
Because the PTH hormone acts on the bone, increases the bone resorption.
Yes, so what? Where does the
It will
alkaline
increase the
phosphatase
alkaline
come from?
phosphatase.
Where does the
It comes from
alkaline?
the osteoblasts.
Osteoblasts, yes. So when there is increased bone resorption, the osteoclasts are active, but bone is a dynamic tissue. So whenever it is resorbed or eaten up, new bone has to be formed. New bone is formed by osteoblasts, and these are the ones that secrete alkaline phosphatase. So since there is high osteoblastic activity in hyperparathyroidism, so the alkaline phosphatase will be high. But here in hypoparathyroidism, there is normal osteoblastic activity. So you expect to find normal alkaline phosphatase. Is it clear?
Yes, doctor.
Okay. If you do imaging, you will find calcification of basal ganglia if you do a CT of the brain at the level of the basal ganglia, like I will show you in a minute. This is an axial CT, like that, cut like that. Bone appears white. Not only bone, but also calcifications, like here. This is the area of the basal ganglia. See, the basal ganglia. The black areas are the ventricles filled with CSF, okay? But here, these are bilateral basal ganglia calcifications, okay? Now, let me tell you about some conditions that look like hypoparathyroidism. We have pseudohypoparathyroidism. When I write pseudo, P-S-E-U-D-O, like that, this is Greek for false. And we have pseudo, that is false pseudohypoparathyroidism. What are those? Pseudohypoparathyroidism, these are several clinical disorders characterized by end organ resistance to PTH. Okay? And they are called pseudohypoparathyroidism. They are associated with hypocalcemia, like in hypoparathyroidism, hyperphosphatemia, like in hypoparathyroidism. But here you will find the circulating PTH to be elevated. Okay? Why? Because there is target tissue unresponsiveness to the PTH. And this can be checked by measuring the cyclic AMP excretion at baseline and then following PTH administration. Normally, it should rise, but in this condition, there is lack of increased cyclic AMP excretion in response to PTH administration. Okay, this test is diagnostic. All right. So how does the patient look like? Remember the boy I told you about earlier? This is actually a lady. She's a lady, but she's short, around the 3rd percentile for her age. And she has disproportionate shortening of the limbs compared to the trunk. Okay, so one cause of disproportionate short stature would be pseudohypoparathyroidism. She has generalized obesity and a rounded, flattened face, and she has also some mental subnormal, the mentality is subnormal. Okay, and if you look at her hands, you see, look at your own hands. She has something called brachydactyly, which means short fourth and fifth fingers with a greatly foreshortened terminal first digit, what we call potter's thumb. You see the potters اللي بيعملوا الأواني الفخارية. And if you ask the patient to do a knuckle fist like that, you see, do a fist, please, you will notice you have knuckles here. The knuckles are visible. But here, where are the knuckles? They are replaced by dimples. Why? Because the metacarpal bones are short of the fourth and fifth metacarpal bones. This is Archibald's sign. No need to remember the name of the sign, but just remember that there are pits replacing the knuckles due to shortened metacarpal bones. All right? And if you do a plain X-ray for this hand of this patient, you will notice that there is a greatly shortened fourth and fifth metacarpal bones compared to the second and third. Is it clear?
Yes, doctor.
Okay. Now coming to pseudohypoparathyroidism. This is a plain X-ray of the right hand of a lady. She's wearing a nice ring. Having normal serum calcium, normal serum phosphorus, and normal alkaline phosphatase, but the X-ray reveals shortening of the fourth and fifth metacarpal bones. Okay, so she has the phenotypic defects of hypoparathyroidism, but without the calcium abnormalities or the abnormalities of calcium metabolism. So this is why we call it pseudohypoparathyroidism. Is it clear?
Yes, doctor.
Okay. So this concludes today's session. If you like, we can, are you tired? Do you have time? We can start with the other session. Can you still see my slides?
No, doctor.
Okay. Can you see my screen at all? Huh?
Yeah, the screen is visible, but there's no slide.
Okay. Time. Would you like to continue? Huh? Answer me,
Yes.
please. I didn't hear. Can you see my slides? Huh?
Yes, doctor.
Okay. Are they small or in slideshow?
They are in slideshow.
Moving or fixed?
Yeah, moving.
Okay, great. We did that already. Sorry. So it's number 4. This one. Can you see my slides?
Yes, doctor. It's slideshow.
Okay, moving?
Yeah.
Great. So the intended learning outcomes of this session are the following. By the end of this session, you will be able to list the symptoms and signs of Cushing's syndrome. You will be able to understand the various imaging modalities in Cushing's syndrome, like pituitary MRI, CT adrenals, octreoscan, another form of scintigraphy. and list the symptoms and signs of Addison's disease, understand the various imaging modalities in Addison's disease like plain X-ray and CT adrenals. You are going to be able to list the clinical manifestations of pheochromocytoma, and you're going to be able to understand the various imaging modalities in pheochromocytoma, namely CT adrenal glands, MRI of the adrenal glands, MIBG scan, another scintigraphy, and MIBG SPECT CT fusion scan. All right? And you're going to be able to list the clinical manifestations of Crohn's disease. You're going to be able to enumerate the biochemical investigations of Crohn's disease, and you're going to be able to understand the various imaging modalities in Crohn's disease, namely CT adrenals and radioactive iodonorcholesterol scan, another type of scintigraphy. Okay? Now coming to Cushing's syndrome. On this slide, you can see the summary of the clinical manifestations of Cushing's syndrome. Usually, it is a lady who presents with obesity, mainly truncal or abdominal obesity. Okay, she has thin, wrinkled skin. She has abdominal striae. She has purpura. She has skin ulcers with poor wound healing. She has amenorrhea. She has muscle weakness, and she has a abnormal distribution of fat all over the body. One of them is the truncal obesity. Then she has the buffalo hump, and she has the moon faces. Okay, she has also osteoporosis, hypertension, and cardiac hypertrophy, and emotional disturbances. And she may have an enlarged cell latricica if she has a pituitary macroadenoma. But usually, ACTH secreting pituitary adenomas are microadenomas. All right? Am I going too fast?
No, doctor.
Okay. Now the symptoms. The patient complains of what? 91% of patients complain of weight gain. 84% of female patients complain of menstrual irregularity. 81% of female patients complain of hirsutism. What is hirsutism? Who can tell me? Huh? Who can tell me what is hirsutism?
hair distribution in abnormal skin hair in abnormal hair distribution female أو male
لا, hirsutism, you never say a male has hirsutism. Why?
female.
Because normally men are hairy. They have hair all over the body. Hirsutism applies only to women. By definition, it means development of or appearance of terminal hair. Terminal hair means thick, dark, coarse hair, like that present on men's body, the bodies of men. Okay? In androgen-dependent areas. What are these androgen-dependent areas? They are the mustache, the beard, the sideburns, sawalif, the chest, front and upper chest, front and back, upper arms, okay, medial and lateral, front and back, and the lower abdomen, okay, and the medial thighs, front and back. These are the androgen-dependent areas, all right? And there is a scoring system called Ferryman-Galway score, by which we quantitate the score of hirsutism. If it is below 8, then there is no hirsutism, okay? It has to be above 8 in order to say this lady has hirsutism. And you have to distinguish between hirsutism and hypertrichosis. Hypertrichosis means, babies are born with this very thin hair, lanugo hair, الزغب ده اللي بنقول عليه. This is not hirsutism. This is hypertrichosis. Hirsutism, in order to follow by the definition, it has to be terminal hair, thick, dark, coarse hair. All right? Is it clear? And never say a man is hirsute. Like you never would say a woman has gynecomastia, because women, after the age of puberty, all of them have developed breasts. Okay? So gynecomastia, by definition, means development of a breast tissue in a male. Okay? Is it clear? Okay. Psychiatric dysfunction is found in 62% of Cushing syndrome patients. 43% have backache, and 29% have muscle weakness. And this muscle weakness, like in acromegaly and in hypoparathyroidism, again, is proximal. It affects the shoulder and the pelvic girdle muscles. So she will tell you, I have problems combing my hair. I have problems bringing something from a shelf high above my head. I have problems tying a knot above my head. I have problems climbing stairs. I have problems rising from stooping or sitting position. I have problems rising from sitting position on the floor. Okay, the same manifestations, proximal. Okay. Fractures are found in 19% of patients, and of course, these fractures are pathological fractures. Why do you think fractures occur in Cushing syndrome? Who can tell me?
Occurs because of osteoporosis.
Yes, of course, very good, because of osteoporosis. And osteoporosis in itself is painless, a painless disease. But once compression fractures start occurring in the vertebrae, backache starts to occur. All right. And loss of scalp hair, this is found in 13% of Cushing syndrome patients. The signs, these are the signs that you as physicians detect when examining the patient. Obesity. Obesity is found in 97% of patients. Mind you, it is truncal in only 46%, but it is generalized in 55%, like the patient we have in the ward. Facial plethora is found in 94% of patients. Plethora means the excessive redness in the face. I will show you pictures. Moon face, moon face, وش زي البدر كده, is found in 88% of patients. Hypertension is found in 74% of patients. Bruising, easy bruising, is found in 62% of patients, and this has a high discriminant index. Yani when you find easy bruising, this means that there is a high possibility of this patient having Cushing syndrome. Red purple stria are found only in 56% of patients, okay? And muscle weakness as a sign is seen more often than as a symptom in 56%. And ankle edema occurs in 50% of patients, while pigmentation occurs in only 4%. Why do you think ankle edema occurs in Cushing syndrome? Huh? Come on, we have less than 1 minute to go. The Zoom call will end. Why is there ankle edema in Cushing syndrome?
They have salt and water retention.
Exactly, very good. And why do you think only 4% have pigmentation? What is pigmentation due to in Cushing syndrome? In other words,